When a patient with diabetics comes with nephropathy, it's customary to think it as a diabetic nephropathy. But just keep in mind, when the patient has these features, along with the nephropathy, even in a diabetic, you should think of a non-diabetic cause of nephropathy. They are the shorter duration of diabetes of less than 5 years in a type 2 diabetic is unlikely to be a diabetic nephropathy. When the patient has no retinopathy and nephropathy in a diabetic, it's very unlikely that it is a diabetic nephropathy because they always go hand in hand. When the patient has heavy proteinuria with preserved renal function, early in the course, it is less likely to be a diabetic nephropathy. When there is active sediments in the urine, because classically diabetic nephropathy has a bland urine. When nephrotic features are strong and difficult to control, think of non-diabetic nephropathy. When the patient has, when the nephropathy is difficult, has systemic features, think of a non-diabetic nephropathy. When the patient has a nephropathy and even with the control of sugars and even with the control of hypertension by RAS, the nephropathy is still progressing, think of a non-diabetic nephropathy. A rapid onset and a rapidly progressing nephropathy is unlikely to be a diabetic nephropathy, which is slow onset, slow progress. And in ultrasound, when you saw a small contracted kidney, it is very unlikely that you are dealing with a diabetic nephropathy, because diabetic nephropathy classically has a normal or an enlarged kidney.